I am thrilled to have this opportunity to share my thoughts with all of you. I'm a clinical and forensic psychiatrist with over 3 decades of experience in California. As a forensic psychiatrist, I've performed over 1,000 civil evaluations of injured workers, both in and outside the workers' comp system. I've lived through and lived with the changes in the law over the years. As a forensic psychiatrist, I have a deep understanding of how each system has rules and regulations. As a clinical psychiatrist, I've treated thousands of patients in and out of the workers' comp system. My primary treatment experience is in the private sector. I understand and I appreciate the phenomenology of serious depression and how chronic pain adversely affects depression. I'm up on the cutting edge of psychopharmacology, which has seen an explosion of treatment possibilities. Currently, I'm in the most advantageous position to comment on psychiatric care, as my current forensic practice in workers' compensation consists primarily of AMEs and some panel QMEs. I've reviewed and I'm familiar with the quantity and quality of psychiatric care given to injured workers. I'm horrified at the quality of psychiatric care in the workers' comp system. Were this the private sector, there would be multiple concurrent medical malpractice lawsuits revolving around treatment below the standard of care. Injured workers in California are treated like third-class citizens when it comes to psychiatric care. I can no longer muzzle my mouth and keep to myself that gnawing feeling that what is happening is both wrong as well as not cost-effective. More than ever, treatment and intervention is about what is most cost-effective. My message is so simple. Competent psychiatric care is cost-effective. In my experience currently, the available psychiatric care is abysmal. Let me use an example. In my private practice, I see a patient for 1 hour initially, and I make a diagnosis and I come up with treatment recommendations. I define the target symptoms and I individualize treatment to the individual's needs and preferences. One size does not fit all. I generally start medication on the first visit, and I ask for a phone call on the following day. Based on that phone call, I either have another phone call in 1 to 2 days, or I increase the dose. I'll add a medication for sleep if that's an emergent issue. I'll keep a close eye on side effects. I will generally see the patient 1 week after the first office visit, and I will continue this frequency of visits until there's a substantial response to medication. This can take weeks. I'll taper my visits to every 2 weeks when there's an initial response, and then I'll further taper to 1 month when the response becomes more robust. Between visits, I'll have some telephone contact. Some patients need this more than others. Between visits, I'll make changes in the dosages of medication. I will refer to and consult with a treating psychologist who will provide psychotherapy. I rarely refer patients to group therapy. Now here's what happens in the workers' comp system. Frequently, a depressed injured worker is not referred by a psychiatrist or the primary physician for treatment. When there is a referral to a psychiatrist, he or she spends anywhere between 15 minutes to 1 hour with the injured worker. A medication is prescribed at 1 dose. The person's referred for a limited number of psychotherapy sessions and regular group therapy sessions. There is no telephone contact between visits. The next office visit is at the earliest 1 month, and sometimes as late as 3 months after the first visit. The psychiatrist spends anywhere between 15 minutes and 45 minutes with the injured worker. There's no coordination of treatment with the psychologist. Sometimes the medication dosage is never changed. Sometimes the patient stops the medication after 1 day or 1 week due to side effects, but no one in a position of professional power knows this. Now, what's wrong with this picture? Plenty. The psychiatric fact is that in 2012, with our many treatment options for the depressed injured worker, especially ones with chronic pain, much can be done. Under proper care, there's no reason why suffering and symptoms cannot be reduced. So much money is wasted in evaluations without proper and effective treatment. So much time is lost from work. There's so much subjective suffering. Chronically depressed chronic pain patients have more pain, which means more depression, and a vicious cycle set in motion. Chronically depressed injured workers participate less in needed PT, and they don't have the drive to get medically better. Without competent psychiatric care, there's a negative domino effect. People do not get better overall because they can't get better. We need to make it attractive for competent psychiatrists to get involved with treating injured workers. We need to attract competent psychiatrists. We need to improve the reimbursement for psychiatric services. The current fee schedule is approximately 25% what is charged by top-tier clinical psychiatrists in the Los Angeles area for office visits. We need to change the rules and regulations by which psychiatrists are engaged and utilized. This change will only lead to a positive cascade of more competent psychiatrists willing and able to be treating injured workers. Most importantly, this will save money and improve the quality of the lives of injured workers. I believe this can be achieved, and I personally would like to be part of this process for change. Thank you.